here at SASMEC. Okay, just hold on a second. Can't find my cursor anyway, but anyway. Okay, so hopefully this would be a brief introduction to the red alert policy. Now, just give me a second. I can't find my cursor somehow. And because Zoom is actually disturbing my presentation, I can't even actually advance my slides. Hold on, let me see whether I can find it. Where is my cursor? Hold on. Hold on. Okay, there you go. Now, is it actually, why is it not moving? Oh.
Dr. Munira, maybe you can unshare and start sharing back.
Oh, okay. Yeah, I can't actually find my cursor, hence that's why I'm struggling. Let me see.
Okay.
How do I exit from here? Okay, getting there. Okay, so let me just start again. Share. Okay, so red alert. Okay, so I'll go through what it is in today's presentation. Why do we need to have it actually, and when do we need it, and how do we actually trigger it, and last but not least, who will actually respond to the red alert system? Okay, let me just wait until the slide goes forward. Okay, so red alert, okay, it is a system of communication. Okay, it enables a fast, efficient, and coordinated response by a multidisciplinary team. So I'll go through who this disciplinary team later on when we see who is actually involved in the red alert. And the response is to a selected obstetric emergency. So it's not all. And again, I'll detail out what kind of cases that we actually trigger red alert in. Okay, but before I dwell further into those details, let's go back to the history as to why we actually need the red alert system. So in order to further reduce the maternal mortality ratio, the confidential inquiry into maternal death was started back in 1991. So it's been ongoing for the last 20 years. So before 1990s, the maternal mortality ratio is about 700 before the independence, down to about 300 a few years before just in the early 80s, and about in the early 90s is down to about 25 to 30. It's been remaining stagnant pretty much actually. So in 1991, they thought that how can we actually reduce this figure further? So this confidential inquiry is a meticulous audit. Actually, we looked through each and why exactly it happened, and the events leading to the death of a mother, because each mother counts. Okay, so within 1 year of starting this CEMD, okay, so it has been flagged up that one of the things that we could have changed in dealing with maternal death, or rather in preventing maternal death, is to actually have a system to coordinate fast response to a maternal collapse. So in 1994, there was a circular for all MOH hospitals to actually have a red alert system. So as part of that, since SASMEC is a new hospital, so we are also introducing the red alert to further, alhamdulillah, we haven't had such cases so far. We did have one case who is being followed up by our hospital, but she went to HTA instead. So alhamdulillah, we haven't actually had a maternal death here at SASMEC, and hopefully we won't. Okay, but we do need to still have this system. Okay, so when do we trigger red alert? So as we can see a pregnant lady here. So it's actually for pregnant ladies of any gestation to about 42 days postpartum. Okay, so it's for anyone. And here at SASMEC, the red alert covers everyone. Sorry, or not to me, I guess. Somebody has unmuted themselves. Okay. Right. So it's for pregnant ladies of any gestation to 42 days postpartum. Okay, and the cases that we trigger red alert for is cardiac or respiratory arrest of any cause, unconsciousness of any cause, eclampsia of fitting, or for example, if you don't know whether the person has eclampsia of fitting, then obviously assess and trigger if needed. Okay, obstetric shock. So obstetric shock can be of any of multiple causes. So it can be a massive bleeding, sepsis, uterine invasion, pulmonary embolism, and also amniotic fluid embolism. And last but not least is unstable cardiac arrhythmias. So there is an overlap between one is a very specific obstetric cases such as obstetric cause, eclampsia. However, there is an overlap with medical conditions or other causes such as cardiac arrhythmias, unconsciousness, or cardiac or respiratory arrest. So hence that's why the need for multidisciplinary team response. Okay. However, just going back to the cardiac or pulmonary arrest of any cause. So that is, I guess, that one may wonder what's the difference to a code blue and a red alert. Okay, so as we know, code blue is a response, is a quick response to any cardio or respiratory arrest for the members of the public. Either it happens in the corridor, in clinics, whilst someone is visiting, in the car park or anywhere. So it's a code blue. However, what happens if the person collapses? Is a pregnant person. Okay, so first of all, it would be it's a code blue if the person collapsing is a member of the public. So you do need to actually trigger code blue first. And if after assessment you found out that the person is pregnant, and after assessment by the doctor, then you actually trigger red alert. I'll go through the flow chart in a few minutes actually later on. It may actually make it even clearer afterwards. Okay. Okay, so how do we actually trigger the red alert? So it's the same number as the code blue. It's 2555. It's 2555. Okay, so it's the extension 2555. You go straight to the security, and they will actually announce just like the code blue announcement is. Okay, so if you think that your area hasn't actually got the speakers, for example, you haven't heard the announcement for Solat or any car park or any parking announcement, so do make sure that you can actually hear this. Okay, especially the responders. Okay, so and if it happens to be in the corridor, you can't get to an extension, there's a direct line. It's 09591 2555. Okay, so it's a direct line as well, so you can actually call it from any number, any phones. Okay, so what you need to do is to state very simply, it's a red alert, where the location is and the level. So for example, if it happened in the pediatric clinic, for example, because we do have postpartum mothers there, especially. So it would be so once being assessed by the primary team where the incident happens. Okay. So either by triggering code blue or because there's doctors there, you can actually call 2555 and say red alert pediatric clinic ground level. Okay, because a lot of the times you don't know where the unit is situated. I get confused where the surgical ward is still, where the ortho ward is still. So do mention the level and the location, specific location and level to the security person. You do need to actually repeat this twice to the security person, and they will actually repeat back what they've heard, so that when they do the announcements, it is very clear. Okay, so it's not like as if like a telephone buruk where you pass the message differently, the next person hears it differently and announce differently. Hopefully that doesn't happen. Okay, right. So who will respond to the red alert? Okay, there's a it is quite a big team because we do need to actually get things going very quickly. Slightly different from the code blue, where you only have, I think you have 3 person, I think, from each unit of the code blue. So when this red alert, when it's being triggered, okay, so all of these personnel will actually respond. So first of all, it will be from the ONG team, it will be the MO, the medical officer, it will be the registrar or the specialist, the consultant will be called as well, but this will be called separately, the midwife and also the PPK. But on top of that, there will be the anesthetic registrar, the pediatric MO or specialist, okay, the medical registrar as well on call, and the blood bank and the blood bank MO will have to actually be on standby, and also the OT staff will also need to be standby. So at least this personnel will need to make sure that you can actually hear the red alert trigger. So when it goes through the announcement, everybody will actually have to respond to this. Okay, so obviously the blood bank staff and the OT staff wouldn't need to run to the location, but they will need to stand by at the lab or OT, and the OT staff will need to prepare the OT actually in case of it being a cesarean section, for example. However, the ONG, anesthetic, pediatric, and medical will need to actually rush to the scene. Hence, that's why the triggering system will need to be actually assessed by either the doctor from the code blue team, the CBR, the code blue response team, or the doctor at the unit. For example, like I mentioned just now, is the pediatric clinic, for example. So the pediatric doctors can actually trigger this, or anywhere actually, because we do have obstetric patients on the surgical ward. We do have obstetric patients on the COVID ward as well, actually. So if this happens, do trigger it actually. However, we also don't want to actually miss the fact that we do have other members of the team as well, actually, because these are the first responder who responds, who first sees the patient, and who first triggers the red alert. That's the security who makes the announcement, which is very important, because without the security personnel, we wouldn't know that the red alert has been triggered. And also with the operator as well, okay, because they do need to actually call our consultants and our specialists if they're not, if it happens out of hours. Okay, so it's not just the clinical staff, but also the supporting staff as well. So it is a multidisciplinary team. Okay, so this is the flowchart that is actually in. Oh, so yes.
Yeah, my name is Dr. Ashri from NS team. I just want to confirm from the clinical staff, according to the responder for the red alert team just now, I see there is a pediatric MO, and then I see MO from the ANG, but for the anesthetic, only for the registrar. I just want to confirm, because in OT, we only have an OT on call for the MO. The registrar will be standby in the ICU. Why the MO in the anesthetic team yang memang dah standby in the in the OT, not be included as the responder, because we are the ones that on call in the OT, and then to prepare for is there any emergency when it comes to the OT or the ONG team.
Okay, so that's a very good question. Okay, so this is the responder who goes to the scene itself. Okay, so the OT on-call person wouldn't be able to actually leave OT, isn't it? If I'm not mistaken, you probably can't actually hear the announcements in OT as well. So what we have, so the previous discussions, what we've concluded is that the anesthetic registrar who is in the ICU, who will be able to actually hear the announcement, will respond to scene first, actually. And if there is a need, if there is a need to go to OT, then they will actually alert their respective teams. For example, if it's a condition that doesn't need OT, and then you don't actually have to I guess the OT person wouldn't actually have to respond to it, but at the same time, be on standby. We did actually discuss about who responds and how many people would actually respond. So if we do want to put everyone in the team, it will be a very big team. So what we've done is we've narrowed it down to just the anesthetic registrar who is on call, who will respond, and the anesthetic registrar would actually discuss with the specialist to coordinate where and how they would actually respond at that time. For example, is it does the anesthetic registrar brings along the ICU MO on call as well, and then at the same time inform the OT person to be on standby, and things like that. I believe your specialist would also do a briefing on red alert for specific to the anesthetic team. I believe that's the way forward as well. Okay.
Okay, thank you, Doctor.
All right, no worries. Okay, so this is the flow chart. So if there's an incident, the first responder, the first responder, the main aim for the first responder is one to actually call for help, and do the initial steps. So I guess the aim, the BLS team is also trying to actually get everyone to be BLS trained. So the first responder will be BLS trained, hopefully, at least start basic life support. Okay. And then the security department will respond to the call. So like I said, it's to just state red alert, location and level, and repeat ×2. The security department will receive the call and repeat back to the caller to actually confirm whether or not the message has got across, and make the announcement 3 times. Okay. So this is where the operator comes in, because the ONG specialist and the consultant on call, if it happens out of hours, may not be on site. Okay, so they do need to actually call them separately. It is thank you very much for the NST team for question just now. So it's slightly different from ONG team, because the responding person from our team would be actually responding to the red alert. So we want to actually spare this person from making calls. So the operator will call the ONG specialist and consultant. So the other team members, such as either the anesthetic team or the medical team, I'm hoping that there is a spare hand, and you would be able to actually call your respective seniors ataupun juniors to support as well. Okay, so the red alert team is to actually attend to the scene immediately. And like I said, blood bank and OT staff to actually stand by, and to actually manage the emergencies there. Actually, so if it happens in the corridor, so like I said, it will be a code blue first. So the code blue team will take the patient to the ED, and I guess in ED they would actually trigger the red alert. Okay, and there is a need to stand down. Okay, so for example, like especially the blood bank, the OT staff, and who would actually be on standby. So there is a need to stand down so that they are not on standby all the time. So once the incident has been managed, so the ONG specialist will decide to whether to stand down the alert, and then the ONG staff nurse will inform those who are not on site, such as the blood bank and the OT. And if, for example, it's if it's not a false alarm, but I guess it's a short occurring incident, and it's settled before other team members arrive, so they would actually be called separately as well. It's most likely that they are already on their way, but if they are still not there yet, we will actually call each person to stand down as well. Okay, so this is the red alert policy, and it is available via the CMU, and that's it actually. I don't know whether there's any questions. I can't actually see the questions if there's any, or we want to actually pass the floor to Dr. Shakur first before we entertain any questions.
Yes, I think we can proceed with the next presentation from Dr. Shakur, since there's no any question in the chat box or our YouTube live. So, Dr. Shakur, you may proceed. Thank you so much, Dr. Munira.
Assalamualaikum. Sekejap Okay, can everyone see my slide?
Boleh, Doktor.
Boleh.
Okay. So, Assalamualaikum warahmatullahi wabarakatuh. So, I'm Dr. Shakur from ED. Okay. So, today we're going to, I'm going to just briefly talk about basic session on pregnant women. Okay. So, mainly it's going to be about CPR. Okay. And as Dr. Munira said just now, first responder should be BLS provider. Okay. And as we all know, all hospital staff should already be trained with BLS either when during their training or during their studies. Okay, so that's why we are considered a safe area in hospital so that everyone collapse. Everyone in the hospital should be able to perform CPR. Okay, so if not, if you cannot perform CPR, honestly, you are endangering our patient, no matter which department you are. Okay. Because you are supposed to be healthcare worker. So make sure you in this lecture, I want to refresh all your previous training before, so that you can, if anything happen, you can perform the CPR when in need. All right. Okay. So I'm just going to share the basic of CPR first in adult. Usually, first, of course, the one with risk factor to have a cardiac arrest or to to have heart attack and collapse is the one with age more than 40. Okay, male. Okay, in our term, in our discussion today will be female. So hypertension, diabetes, hypercholesterolemia, smokers, and also got family histories. Okay, this is basically is the basic lah. So usually in pregnant ladies, you already in Malaysia we have a very strict screening and health screening and also monitoring for the pregnant ladies. So usually we can see in their pink book all the risk factor already written on the pink book. Okay, so if they have hypertension, diabetes, hypercholesterolemia, so they are at risk of IHD, and they might have cardiac arrest. All right. Okay, so so far for CPR, what we notice that we as a healthcare worker and also public do wrong are this list, which is 1, too many interruption during chest compression. Okay, too many interruption. While doing CPR, then you stop, you call someone, you call your MOs, okay, or you go get a trolley instead of one person just performing CPR without any interruption. Okay, so another thing is that the rate is too slow. The rate is usually less than 100. Okay, or sometimes the rate can be too fast. Okay, the rate it should be around 100 to 120. Okay, and then the compression, the chest compression is too soft or shallow. Alright, terlampau perlahan dan juga terlampau tak dalam dia tekan dia. Alright, the depth, okay, kedalaman dia when we do a chest compression should be around 5 cm. Right, and then hyperventilation, meaning that when you giving the rescue breathe, it should be around 6 to 8 seconds if the patient already intubated. If not intubated, as usual, after 30 compression, 2 rescue breaths. Okay. All right. Okay. In US, despite their training, they are very well in training. They are very well in creating the awareness of BLS. Okay. Only is less than 40% of people collapse in public receive CPR. Okay. And then only lesser than 12% apply AED. Because in US, their AED, there are more awareness on AED. There are more AED available. Okay, AED ni automated external defibrillator yang bagi shock kepada patient. Kalau if needed. Alright, so this is the latest change of survival. Okay, previously always they have only one chain of survival, but last year they put two change of survival. One is in IHCA ni ialah intra hospital, okay, intra hospital cardiac arrest, intra hospital chain of survival, okay. Inter-hospital cardiac arrest, chain of survival, and then the OHCA is outside hospital, chain of survival. Okay, so for us, intra-hospital, we as a healthcare worker should be able to recognize, okay, early recognition. Okay, tak boleh sama macam orang awam. Ni pengsan ke? Apa ke ni? Tengok-tengok dulu, panggil-panggil orang dulu, tak boleh. We are healthcare worker, tengok je, we should know this is cardiac arrest. Okay, this is collapse. Okay. Okay, so when we recognize early, okay, of course we need to do prevention by training and all. Okay, when we recognize early, we need to activate the emergency response. Okay, in emergency we have a resusc bell. Okay, so in ward, some of the ward you have emergency bell, right? Okay, or if not, you just shout. Okay, shout for help. Okay, you don't go run to the nurse counter to shout for help, to ask for help. You don't go to the doctor saying, doctor, patient ni macam pengsan lah. No, okay. You just shout for help, activate the emergency response, and you perform high quality CPR. Understand? And then get the AED. In hospital usually we don't have EED in ward, but we have the manual defibrillator. Okay, take the manual defibrillator, another person to attach the cardiac monitoring, and recognize the rhythm. If there's MO present there, the MO should recognize the rhythm. All MO should have ACLS, okay, and then all staff healthcare workers should have BLS. Okay, so defib when you need, okay, and then if not, continue CPR. Okay, can someone who unmute the mic, can you please turn off the mic? Okay, so after that, of course, post cardiac arrest care if a patient revive. If not, then of course we will I will teach later when to stop CPR. And of course, after that is recovery. Outside hospital is different. Okay, when you notice there is a collapse victim or patient, activate emergency response. Okay. And then you perform CPR, defib, wait for paramedic to come to continue advanced resuscitation, and then post cardiac arrest care and recovery. Okay, I think it's not much of the difference, but the difference in intra-hospital care cardiac arrest is the early recognition and prevention. Right? So we as a healthcare worker should be able to early recognize. Okay, so this is I think very familiar to everyone. It should be okay. DRSABCD, or dulu saya panggil Dr. Subsidi. Okay, Dr. Subsidi. This is very important because when you are in panic, you should calm yourself, take a deep breath, and remember this Dr. Subsidi. Okay, and it will help you to do everything one by one. First, check for danger for the patient and yourself. Then check for patient responsiveness. Okay, jangan patient tu jatuh je terus activate code blue, tak check pun lagi responsiveness. Kejut-kejut, actually dia bernafas, dia boleh bercakap, semuanya singkup saja. Alright, so check for responsiveness. Okay, alright. After check for responsiveness, okay, S is for shout for help or shout for 999. Okay, or emergency trolley. Basically, shout for help. Right? A is for airway. Open up the airway and see whether there's anything that blockages the airway. Right? Okay, if no, check for the breathing. Okay, is the patient breathing or not? And then, okay, we wait for the doa recitation.
Itu kita nggak pakai mas punya tuh pakai mas ini kami.
Okay, so just now we are at airway. Open the airway, check for any airway blockage. Boleh mute tak? Siapa ni? Cuba tengok siapa yang unmute ni. Can you all please check your microphone, right? Because this is for everyone, so you are disturbing everyone, right? Okay, so check the airway. If no airway blockage, so you check for any bleeding or not. If no bleeding, straight away start chest compression. All right. If because we are healthcare worker, we are able to check circulation during the airway and bleeding check. All right. If no pulse, start chest compression and early defibrillation. Okay. Okay. Do you all understand so far? Susah cakap dengan screen ni, right?
Yes.
Okay, so danger, of course, I already briefly explained. I think all of you already familiar with this, so I'm not going to go in deep, but I just go quickly. So danger, of course, for not just for patient, just also for ourselves in current situation, pandemic, COVID-19, ourselves first. Okay. Always ourselves, actually always ourselves, but we need to emphasize more in this current time. Wear appropriate PPE, okay, appropriate mask. All right, if you are in COVID ward, make sure you wear at least N95. If you are at the normal ward, at least normal mask. But in this current pandemic, if patient collapse, always wear N95. All right, always N95 because we don't know why they collapse. It might be COVID. And if you're wearing normal mask, it still can expose you to the aerosol generating procedure during the CPR. Okay, because CPR is aerosol generating procedure. All right. So wear appropriate mask, N95, apron, and glove. All right. Avoid spilling any body fluid, sharps, electrical wires, and then determine. Okay, make sure the bed is stable. Okay. If patient collect on the chair, you lift up the patient, put on a stable bed or on the flat surface on the floor. Okay, but in our hospital, the best to be on the bed. Okay, because we have a lot of beds, right? And then check for response. Again, check for response first. Remember, after you check danger for yourself and your victim or patient, okay, check the response first. Before shouting for help. Check for response, okay? Tap the shoulder, okay? Ask the patient, are you okay? Ataupun, hello, are you okay? Okay, pakcik, okay ke tak? Anything, all right? Anything. Just check for any response, okay? If no response, no response at all, nafas pun tak ada, buka mata pun tak ada, apa pun tak ada, all right? Then you shout for help, okay? Suspected for cardiac arrest. Okay, as we mentioned now, you can call 999. You can call your team to bawa trolley resusitasi. You can ask someone to ring the resus bell, okay, to get help. Alright. Tapi kalau because in our situation in hospital, you have a lot of people around, so you don't leave the victim around. But if you are only alone with the victim, then you need to go get the help. Okay. All right, and then position the victim lie flat semua, and then for pregnant lady, I'm going to discuss later how to position the victim, and then open the airway. Okay, open the airway. We use the head tilt, chin lift. Okay, head tilt, chin lift. Okay, and then look for any airway obstruction. Open the mouth, look for any airway obstruction. If you see anything obvious, you can take it out. All right. And then look for the bleeding, okay, just by looking at the chest, neck and face, not more than 10 seconds, all right? You should be able to see any chest rise or not, okay? Not more than 10 seconds, all right? Previously, we have look, listen, and feel. Now we don't, they in AHA, they remove this, right? And then if absent of breathing, or you notice there's abnormal breathing, agonal breathing, for example, okay, it's equal to cardiac arrest. Or patient gasping, and so it can be considered as you need to perform cardiac arrest, right? For us, healthcare worker, again, I mentioned earlier, we are allowed to feel for carotid pulse less than 10 seconds. I think everybody now should, kalau tak tahu macam nak pegang carotid pulse tu, I think you should learn now. Okay, okay, check for your Adam apple tu. Okay, kalau perempuan pun rasa macam ada prominent sikit in your neck, in the center, just about 2 finger breaths on your left side or the right side. Then you press deeply over there, you can feel your pulse, right? That's the location. If no pulse, is pulseless, then you need to start chest compression. Chest compression, okay, you need to apply enough pressure, okay, with a beat around 100 to 120 per minute, okay. You should put your hands, okay, at the lower half of the sternum, okay, lower half of the sternum. Kan, tengah-tengah ni kita ada sternum ni, alright, then the lower half and ataupun center of chest, right? Okay, push hard and push fast. Okay, remember earlier the problem is too slow and too shallow, right? So that's why it always said push hard and push fast during CPR, alright? Okay, this one is so healthcare provider or layperson can also do chest compression, all right? Okay, again, chest compression, the side of hand placement is at the lower half of sternum. Okay, put your heel, you punya yang keras apa? You punya tapak tangan tu, yang bony part tu, dekat pangkal you punya tangan tu. Put your heel of one hand at the center of chest, dekat tengah-tengah chest tu. And another one is on top. Satu lagi atas, and then jari, selang sama jari, and then you kena straight your arm and lock your elbow, okay? And then you start chest compression 100 to 120, depth about 2 inches or 5 centimeter, okay? And then we allow complete chest recall after the chest compression, okay? Bila chest compression tu jangan tekan saja, kena naik balik biar dia buka balik kepada asal dia, baru tekan balik, okay? Alright, so allow to hold chest compression less than 10 seconds. Okay, maksudnya when you are giving, because the compression is 30 to 2, when you stop for giving breathing, you should allow only 10 seconds. Alright. Okay, this is the location. This is the heel of the hand, letak dekat center of the chest. This is the sternum, so ambil lower half of the sternum kat sini. Alright, and then another hand letak kat atas. Alright. Lepas tu interlocking the fingers, lock your elbow, your body above the patient and start chest compression. Okay. Ini macam daripada, if you see it, this is picture. If you, it looks like you are compressing the heart. Okay. The reason you compress the heart is so that the blood in the chambers will start to flow. Okay, because our heart is only our blood system, vascular system is only one way punya flow, so dia takkan pergi ke belakang. So dia akan every time you press, it will compress the blood to flow in the right direction. Alright. Okay, so for pregnant lady, if more than 20 weeks, more than 20 weeks, okay, or the uterus is palpable or visible. Okay, dah boleh nampak uterus dia, dah boleh nampak dia punya ni, you can palpate. So you can do two ways you can do. One is you do the left uterine displacement, one hand technique. Another one is that left two hand technique. Sorry, aku tengah teaching. Kejap, nanti aku balik. Okay. Okay, so if patient pregnant, okay, one doing CPR, another person should push the uterus. Okay, push the uterus to the side. Tolak rahim tu ke tepi, sebelah kiri pesakit. Alright. So to the left side. Nanti kita, later I will tell you why to the left side. Okay. Either one hand technique or two hand technique. The best is that if you can provide macam wedge, wedge about 30 degree, letak ke belakang dia so that she is slightly to the left lateral about 30 degree, and then you perform CPR from the side. Okay. Okay. Why? Why? Because if they are lying flat, okay, you see our blood vessel, main large blood vessel, okay, descending aorta, and also our vein, inferior vena cava. Okay, this is picture from top, from top. So meaning that this is from the right side of the mother. This is from the left side of the mother. So when you turn the mother to the left side, okay, it will opens up the blood vessel. Okay, if not, the fetus, the uterus will block the blood vessel. Okay, that's why you need to turn the mother to the left side. Okay, to open up this blood vessel so the blood can flow. Right. So again, during chest compression, we minimize interruption. Okay, compression is 30 to 2. Everyone should know this. Okay, rescue breath only should be given by a trained rescuer, by mouth to mouth or back to valve. Okay, but in our current situation, COVID, okay, back valve mask only. All right, back valve mask only. You don't do mouth to mouth. Okay, all right, and then you should do head teaching lift during opening the airway to give rescue breath, and every rescue breath only about 1 second, over 1 second. And then you should give enough tadi volume, enough air inside to the to the lungs to produce visible chest rise. Kalau if you see the chest already rising when you back the patient, it means that it's enough. Okay, but if you don't see the chest rising, it means it's not enough. Right, that will be around 500 to 600. Okay, if patient already intubated, all right, you should give rescue breath 5 to 6, one breath in between, one breath every 5 to 6 seconds. Okay, 5 to 6 seconds only. Right. And then you don't need to stop CPR. You don't need to stop chest compression if already intubated. So someone who do chest compression should do chest compression straight away for 2 minutes, and the other one who in charge of the airway should just give back valve mask, give one breath every 5 to 6 seconds. Okay, this one is kita punya one of the device that we have, is a face mask, right? So currently we are not advising this one at this moment because of the COVID-19. Okay, use back valve mask only, right? This is if 2%. Okay. Okay, so this is just want to say that a good CPR, good chest compression will give only actually 1/3 of cardiac output. So paling bagus punya chest compression pun sebenarnya 1/3 saja darah yang keluar daripada jantung tu, cardiac output itu panggil, berbanding dengan normal, compared to the normal our own normal cardiac punya compression, right? Okay, why is it important? It's very important. You need to do chest compression because you need the blood to go to the brain, kan? Darah tu nak kena sampai ke otak. Kalau tak, otak akan mati, right? So that's why ada statement ni dia kata, why is it that every time I press on his chest, he open his eyes, and every time I stop to breathe for him, he goes back to sleep. So bila buat chest compression, tiba-tiba orang tu buka mata. Alright, orang tu buka mata. You, siapa yang pernah CPR, sometimes you see this. When you start CPR, patient bergerak, right? You bila bergerak, you pun stop. Tapi bila you stop, dia pun stop. Okay, because blood dah tak pergi kat otak. Alright. So kalau macam tu, you kena continue CPR, right? So so why? Because we want to maintain the cerebral perfusion. Okay. the first 10 minute. The first 10 minute ni, kalau kita tak perform CPR in the first 10 minute is actually not good for the brain. Okay. Alright. This is the most important point. Kenapa kita kena, why we need to start CPR, chest compression early. Okay. Lama pula kan. So if chest compression not properly performed, kalau chest compression tu not perform properly, the location of your hand is not proper, you can result in puncture of the lungs from the fracture of the ribs. Okay, you can lacerate the liver, and of course you can fracture the ribs and sternum. Right? Okay. Then we go after chest compression, defibrillation. If there is one rescuer, you are alone. After activating the emergency response, okay, you should take immediately the AED. So if you are alone, when you see this patient collapse, you are alone, nobody else. Okay, you shout for help, nobody else. You should go activate the emergency response. Okay, if you know where is the AED, if you know where is the emergency trolley, you should take the emergency trolley and start to attach to the patient. Okay. Dah ambil semua ni baru start CPR. Okay, because you are alone. But if you are more than one, okay, one start compression immediately, another one should activate the emergency response as mentioned earlier. Okay, defibrillation, if we have AED, is very simple. AED ni sangat simple. Okay, dia ada color coding, dia ada lampu, dia ada nombor, ada macam-macam jenis. Alright. So, bila you buka je, you turn on saja, dia ada arahan 1, 2, 3. Okay. So, kita just follow je apa arahan AED tu. Dia ada bercakap juga. They can give instruction. So, they say apply, connect the pad to the AED. So, connect pad to the AED, attach the pad to patient, Kan? Stop CPR. So, dia akan bagi direction one by one. Alright. We just follow. Okay. And then if they said shock, you give the shock. After shock, you straight away start chest compression. And then after about 2 minutes, they will ask you to stop again. And they will check the rhythm for you. Okay. This is the example. All right. You see there's 1, 2, 3. You open je. Okay. There's instruction 1, 2, 3. You open 1, turn on. Okay. You turn on, you will listen to the instruction. They will ask you to attach the pads. Okay. And then they will ask you to attach the pads to patient. Okay. After that, they will ask you to stop CPR. After that, they will analyze and they will say to you some other to continue CPR or to give shock. Okay. It's very simple. When to give shock, you just press this button. Nampak ada kilat ni. Make sure nobody is touching the patient and you press the shock button. After that, throw CPR again. Okay, this is another type. Okay. Okay. Yang ni is the location for the defib juga manual defib. Okay. The later you defib, okay, the lesser chance of survival. Okay, lagi lambat you defib, lagi lambat, lagi banyak, lagi besarlah kemungkinan untuk dia mati, right? Okay, so assessment, bila nak assess, when are you going to reassess patient? It is actually after every 5 cycle of 30 compression and 2 rescue breath, 5 cycle benda tu, or 2 minutes of CPR. Okay, then check, kita kena check sama ada dia ada bernafas lagi ke tak, ada pas ke tak. Alright, when to stop, if victim recover with normal breathing, okay, dia dah bangun dah, dia sedar, dia bernafas yang biasa, you stop. Rescuer is exhausted and you are alone. Okay. Or you are, there are only 2 of you, tak ada orang lain datang, both dah penat sangat, tak boleh. Okay, so you have to stop. Advanced life support assistance sampai. Contohnya, ada orang lain yang lebih hebat sampai. Contohnya MO dah sampai. So MO dah tolong start pasang pad apa semua tu, then dia nak take over. Tapi kat hospital kita lah kan, paramedik pun kita lah advanced life support tu, right? So rescuer should be encouraged to switch chest compression every 5 seconds or 2 minutes. So you don't do straight nak terror sangat CPR seorang-seorang. Okay, you cakap airway je. I biar CPR setengah jam. No, because we want to avoid fatigue and we want to have effective CPR, effective chest compression. Every 5 seconds or every 2 minutes you change. Okay, and then after that you put in recovery position. Okay, recovery position I think semua orang tahu. I don't need to explain this. Alright. And then hands-only CPR. Actually, at this moment, if you don't have the equipment for to give rescue breath, you can only do hand-only CPR. Okay. Okay. So in just update on the 2020 punya for pregnant lady. Okay. In pregnant lady cardiac arrest, we focus on the maternal resuscitation. Mother. We focus on mother. We focus on mother. Okay, with preparation for early premorbtem seizure. Maksudnya kalau boleh dia nak keluarkan baby tu secepat mungkin. Kalau perlu. Untuk selamatkan baby dan juga untuk selamatkan mother. Okay. Walaupun tak cukup bulan So that's why we have this red alert, because we want to make sure mother-mother ni boleh diselamatkan dengan cepat. That's why kita panggil NS, kita panggil ONG team, panggil PITS team. Sebab kalau PITS tu ada baby, mother tu ada baby, PITS team kena tolong resus. Kan? Kalau dia pregnant memang perlukan premorbtem seizure, kita perlu ONG. Dan NS perlu ada kat situ untuk standby juga, untuk help dalam resuscitation. Okay. Okay, so because yang ni ada update dalam 2020 punya HA, okay, pregnant lady ni dia selalunya more prone to hypoxia, kurang oksigen. So first, kalau awal-awal tu kena prioritaskan oksigen untuk patient ni. Alright, and then tak digalakkan, it's not recommended untuk buat fetal monitoring. Contohnya patient ni collapse dekat ONG. Kan, dekat nauzubillah, dekat labor room ada fetal monitor apa kan, CTG apa semua, tak perlu pantau, fokus on mother saja. Alright, fokus on mother saja, sebab akan melambatkan, mengganggu, we are going to disturb the CPR. So and then if possible, kalau nak buat ni kat resuscitation ni NS lah, ataupun intensive care, you want to remain targeted temperature, maksudnya nak buat hypothermia punya terapi. Okay, and then yang ni pun hypothermia terapi. So dia kata yang ni saya rasa tak penting untuk discuss kat sini lah. Ini more on the advanced punya. Okay, alright. So yang ni is dia bagi tahu kenapa lah, what is the reason, because the airway ventilation and oxygenation are important, okay, in the setting of pregnancy, sebab dia increase maternal metabolism, okay, dia punya lung punya capacity tu reduce, okay, because of the rahim ataupun kandungan yang besar tu akan push dia punya paru-paru ke atas, so dia punya ruang tu berkurangan, so dia akan lebih cepat untuk dapat hypoxia. Okay, so dan dia kata untuk check for the fetal heart is not helpful, tak membantu during resuscitation. Okay, so this is the BLS and SLS punya algorithm, the latest one. Okay, if you look here, okay, if patient is collapsed, okay, you should perform obstetric intervention. Yang tadi kita cakap tadi, lateral uterine displacement, dan kita push dia punya uterus to the left side. Okay, detach the fetal monitor tu, cabut semua, tak payah mengganggu. Alright, prepare terus for premorbtem seizure. Prepare terus for premorbtem seizure. So kalau tak ada line, someone boleh tolong cari line. Okay, if the resus team already arrived, someone tolong cari line apa semua. Okay, just prepare for premorbtem, ambil the premorbtem set ataupun ONG akan buat premorbtem set, dan perform premorbtem kalau tak ada pas langsung dalam masa 5 minit, within 5 minutes, within 5 minutes of CPR by right. Okay, untuk ensure the best recovery for both baby and mother. Alright. Okay. Yang ni untuk treatment lain. Okay. So if patient ada cardiac arrest, untuk advance care response, if ada cardiac arrhythmia, so you just perform like a adult punya ACLS. Okay. Alright, any question? Panjang pula. 9 dah. Sorry lah. Any question? Do you guys understand or not? This is very important.
Doktor, ada satu soalan. Salam doktor, saya nak tanya. Untuk CPR ibu, kena tolak sikit uterus ke kiri kan?
Yes.
Ada kata tak ada orang untuk bantu. Bolehkah kita mengiringkan sedikit ibu dan letak bantal di belakang ibu?
Boleh, boleh. Boleh. Actually, in ED also, kadang-kadang we don't have time. We just ambil blanket, alright? Blanket, we just lipat blanket tu, tebalkan sikit, then we mengiringkan sikit. Alright? Good question. Siapa tanya tu? Syakir ke?
Ya, Wan Indra Lily. Wan Indra.
Wan Indra Lily. Yes, betul.
Okey, kalau tak ada apa-apa lagi soalan, kita boleh teruskan. Okey, Dr. Syakur.
Okey.
Okey, terima kasih. Terima kasih Dr. Syakur. Okay, InsyaAllah kita teruskan dengan next presenter daripada Dr. Suhaila. Saya pas kepada Dr. Suhaila.
Tak ada pun. Siapa yang buat? Siapa yang buat tu? Oh, tak ada.
Dr. Suhaila, are you there?
Ya, boleh nampak ke skrin saya?
Boleh, boleh.
Okey. Assalamualaikum warahmatullahi. Okay, my topic today is basic airway management for pregnant lady. Okay, I will go very fast because of the time limitation. Okay, so my outline will be anatomy and physiological changes in pregnancy and basic airway equipments. For the second point, actually, I'm dedicated this lecture to staff nurses and non-anesthetic MOs. Okay, how do they, the pregnant lady differs from the rest? So basically, in pregnancy, there will be increased progesterone and enlarging uterus. Both will contribute to increased oxygen consumption and reduce and increase in work of breathing due to reduction of the certain lungs capacity and lungs volume. Okay, in summary, so basically as the pregnancy progress, patient will have increment in weight. So patient, the airway become more difficult. Patient will have a short neck. So intubation will be difficult. It 8 times more difficult compared to non-pregnant, and risk of failed intubation is 1 in 200 parturian. Okay. On top of that, there will be breast enlargement in which laryngoscope blade insertion is difficult. That's why we choose to use a short handle blade rather than usual blade. But as far as I know, there are no short handle blades available in the ONG wards. Okay, patient also we have airway edema. This will affect the choice of the ETT, in which usually the size used in pregnant lady will be smaller as compared to non-pregnant lady. Okay, the respiratory basically the chest wall due to the gravid uterus, the lungs volume will be reduced, total lungs volume reduced, in which the functional residual capacity is markedly reduced, in which patient are predisposed to hypoxia more rapidly compared to non-pregnant population. On top of that, there will be reduced lower esophageal pressure and also reduce gastric emptying, especially in women who are in labor. This predispose patient to aspiration. In short, if you can't remember this diagram, you just remember these 3 points. Difficult airway, easily to get hypoxia, and at higher risk of aspiration. So when at any emergency ataupun at any when red alert activated for any cause, whether it's due to bleeding or due to respiratory arrest or unconscious, I hope everybody we first can, despite of other resuscitation, don't forget to give oxygen supplement to the patient via face mask or non-breather mask if patient still having spontaneous breathing. This is to increase the oxygen store for the patient. So hopefully the desaturation will take place more slowly when there is apneic episode. Okay, when there is an emergency, usually we lost ourselves, in which we don't know our role. So basically, in resuscitation, at minimum of 6 person must be around. When we activate the red alert, the primary team will be there, and help from other departments will come, and we have to resuscitate patient together. Okay, so usually the team consists of team leader, which make a decision and give instruction to the team members. If CPR is needed, so one will take place in the CPR and one for airway management. So these 2 person can rotate. There will be defibrillator nurse who check the defibrillator machine, the medication nurse who prepared the drugs as required, and we should have one timekeeper and recorder who going to chart the drugs given to the patient and time the CPR for example. Okay, with this 6 person should be around, and with help of some runner who get the things that are not reachable at the bedside. Okay, I focus on the airway equipments. Okay, I know that usually, especially the staff nurse in ward will get panic when anesthesia MO come and decided for intubation. Okay, basically every day you already check the equipments in your emergency trolley, so you just get familiarized with these equipments. Okay, so the acronym are MELSS, MELESSS. So you should have mask, airway, laryngoscope, endotracheal tube, suction, stylet, shrink, and stethoscope. So we will go to one by one. Okay, first is the bag and mask, which we usually call it embu bag. You must know how to assemble the bag. So during emergency trolley checking, you should be able to do this and make sure that the equipment is functioning. Okay, there are 2 types of masks, one with air cushion, in which you should inflate the air cushion, and another one that down below at the below is without air cushion. How do we choose appropriate mask? So basically, it must cover the nasal bridge, cover the chin, and also the angle of the mouth. Okay, all equipment must be readily available and prepared before the anesthesia MO come. And in fact, for back mask ventilation, you can do while waiting for us to come and do a definitive airway management. Okay, how do we hold the mask? Okay, ideally we should have practical session so that you know how to, you can practice. So basically you have to compress C, your thumb and pointing finger, C, and then the E to extend. C, E, C clamp, we call it EC clamp. Okay, make sure that you are not compressing the soft tissue like in the photo, the second photo. Okay. Okay. This is importance of head tilt chin lift. When patient become unconscious, the tongue will fall back and obstruct the airway. So you can see with the simple maneuver, you can open up the airway. On top of that, we can use the oropharyngeal airway, or sometimes we call it girdle airway, to prevent the airway obstruction from the tongue's fallback. This is the second picture is on how we measure how do we choose appropriate size for oropharyngeal airway. So from the angle of the mouth to the tip of earlobe. So when you give the oropharyngeal airway, you must give the appropriate size. If not, it's gonna be defeat the purpose, and in fact, it can further obstruct the airway. Okay, this is laryngoscope. When I say handle, means that like a picture number 2 is handle. So usually short handle is a choice for pregnant lady, but we can use the normal handle. Okay, in ONG usually you have the thin handle. This is for pediatric. Don't give thin handle for adult patient. Okay, then we have blades. So for adult, you must know how to assemble and disassemble the blade. Okay, when you check the laryngoscope, please do this and make sure that the battery is always inside the laryngoscope. Don't take out the battery and put somewhere else, because during resuscitation, sometimes there are lots of things on the emergency trolley, so it will slow the process of intubation. Okay, give appropriate size. Okay, you can see the size whether at the side of the blade or at the posterior of the blade. For adult, please give size 3 or size 4. Okay, sometimes in the set there will be a size 2. Don't give us a size 2 for adult unless we request to use the size 2 blade. Okay, this is endotracheal tube. Okay, in the circle is the size of endotracheal tube. So before we come, you just have to prepare size 7.5 or 7 ETT. Check the ETT cuff. ETT cuff yang bulat dekat hujung ni. Okay, make sure fully inflated. Check for any leaking. Okay, then you lubricate using lignocaine or KY jelly. Then deflate. Fully deflate the ETT before we insert to the, after checking, so that when we insert to the patient, the cuff is deflated. Okay, don't forget to put the stellate. Most of the time we use stellate. Okay, this is to make sure the ETT is stirred enough so that when we insert to the Walker cord, it can help us for the insertion of the ETT through the Walker cord. Make sure that the stellate are not protruded out of the tip of the ETT. Okay, then the shape should be not too curvy like the last picture. It just slightly curved but not too curvy, because if it is too curvy, it's also will cause difficulties in insertion of the ETT. Okay, suction, make sure suction is functioning. We usually use Yonker suction, and sometimes we might ask for soft suction catheter. So make sure both suction catheters are available in the emergency trolley. Okay, the last thing is the plaster. So once we successfully intubate the patient, we must plaster the ETT. This is how usually we plaster ETT. Please give us the non-woven plaster rather than the paper plaster such as micropore. So you must have a readily cut plaster with the size of about 1.5 centimeter wide and around 20 centimeter long. Okay, I think that's all from me. It just recap of the undergrad staff for most of the MO, and for the staff nurse, I hope you can relearn about the airway management. Don't get panic. Just make sure that we are ready all the time, because the emergency will come to us without any alarm actually. Okay, that's all from me.
Okay, Alhamdulillah. Is there any burning last question that we can ask from the Zoom? Ada sesuatu nak tanya? Kalau tak ada, kita bagi 10 saat lah untuk tanya soalan. Dr. Asri ada nak tanya soalan ke? Okay, I think kita tak ada soalan. Okay, terima kasih banyak kepada semua speaker, Dr. Suhaila, Dr. Munirah, Dr. Syako. Terima kasih banyak untuk kepada semua untuk attend CME kita pada hari ini. Kita harap Red Alert ni akan berjalan dengan lancar lah. So, kita akhiri majlis dengan tasbih kafarah dan surah Al-As. Okay, terima kasih semua. Assalamualaikum.